Hello and welcome to this ISACOS webinar series presentation on bone marrow edema incidence, effects upon joint function and treatment. My name is Daniel Grandi, and it's my pleasure to serve as a co-chair of today's webinar. We are delighted to be partnering with the ICRS on this webinar. Dr. Fabio Scaretta will co-chair the webinar with me. And with that, I'd like to just set the stage for what the topic we're going to cover today. If I could just share my screen.
Dan,
yes.
While you solve it, I catch the occasion just
Okay.
to say hello. I'm Fabio Scaretta from Rome, Italy, and it's a big pleasure being here with all of you. Good morning and good evening to everybody from all over the world. You have really the occasion to have a great event organized by ISACOS with also an ICRS agreed faculty. Dan is really the actual president of ICRS Society, and among the speakers we will have also Alberto Gobbi and Norimasa Nakamura that are past presidents of ICRS Society. So it's a great faculty that will take us in this topic of the bone marrow edema. Did you solve the problem?
No, I think we could move on to the first speaker. So why don't you introduce our lineup, our first speaker, and we can go from there, I think.
Okay, we just have a little difference among the program because Noga Shapshin will jump in Israel. They have some issues, actually, as we all know. So she'll jump in at the end. So the first speakers will be John Lane, who will speak about the current concepts of subchondral bone pathologies. Then we will have Alberto Gobbi presenting his treatment with the osteochondroplasty, and we will finish up with Nori that will present instead the treatment with MSCs. I please remember to all of you that we wish to have a very interactive webinar, so we wish to ask you to send the questions to all the faculty, and we certainly will address all these issues. You have, as you all know, the question and answer box on your Zoom page. And following the presentation, please take note that we'll have a series of clinical cases that will be introduced and discussed with the faculty, and I hope with great also questions from all the audience. So I won't lose any more time. At this point, I would please ask John Lane from San Diego, US, to be starting this webinar. Please, John.
Thank you, Fabio and Dan. It's lovely to be here. Bright and early San Diego time, but welcome from all around the world. And what I would like to do is start this off sort of hoping Dr. Shapshin can join us later, but I would like to talk about subchondral bone function and pathology. No relevant disclosures with this. The focus on articular cartilage has been one of the major issues with respect to joint damage and joint pain. Part of this is, I think, the specialized nature of the tissue with limited generation of the articular cartilage. In the past, it was felt initially not to be able to be regenerated. We found that's not the case. It reduces friction between the articulating surfaces and it's load bearing. But the question is, let me go back here. What is the real pain generator? You see these two examples of articular cartilage damage. Is this what's causing the articular pain, or is it something else? And we know that articular cartilage is aneural, and so is that the major generator of pain? Why is this so important? Well, because there's such a high incidence in patients, particularly as you reach middle age. You have some type of trauma, you develop chondropenia, injury, chondropathy, and the progression of osteoarthrosis. So in looking at this, our focus has really changed from really being what's the cartilage doing to what is the organ of the end of the bone at the joint doing. We have articular cartilage, we have our calcified cartilage layer, we have the subchondral bone, and beneath that, we have the trabecular bone. So in this H&E stain, you can see the articular cartilage with the chondrocytes. You see the tide mark between that and the subchondral bone. And here's a little bit of the vascularization. And I think in the past, the role of the subchondral bone has been really underestimated. It's a shock absorber, it's highly vascularized, and repetitive overloading or perfusion abnormalities may lead to osteonecrosis, osteochondritis dissecans, or degenerative joint disease. And we now realize that it really provides the nutrition to the deep layers of the articular cartilage, the calcified cartilage layer. You can see here that 50% of the glucose, oxygen, and water is provided to the deepest layer of the hyaline cartilage. It's very vascular, and that poses one of the dilemmas in a lot of our pathologic states. The blood flow is 3 to 10 times higher than cancellous bone. It provides direct nutrition to the calcified cartilage layer, and also through diffusion, it also provides nutrition to the deeper layers of the articular cartilage. Where we run into problems is the loss of an equilibrium between the stimulus to the joint and the bone remodeling below. And that's how we maintain the normal homeostatic mechanism. How does this occur? Well, it can be traumatic, as you see here, with contusions, fractures, or things like root tear of the meniscus, where it really changes the loading characteristics. It can be avascular necrosis or atraumatic changes that affect the integrity of the subchondral bone. And so we really need to look at this as an organ. Because of this, you see there's a great variation in the thickness of the articular cartilage. The tibial plateau is quite thicker in the subchondral bone, much thicker in the central portion than the periphery. And the trabecula bear both compressive and tensile loads. And you can see here that there's quite a few chondrocytes in the upper layer. In the normal state, you have resorption going back to formation. But what you see really at the left-hand side over here is you get thinning of the articular cartilage, you have abnormal load bearing, you have sclerosis, and this starts out the whole pathologic cascade to osteoarthritis. What do we see in the subchondral bone? Well, if we look at the mesenchymal stem cells, we see that the activity is decreased of these progenitor cells. We see loss of MSCs and osteonecrotic lesions and downregulation of osteogenic potential. So we lose the capacity to redo that. We see in an example on this X-ray, we have subchondral edema that's not able to be seen except by MRI, but we see osteonecrosis, insufficiency fractures, and SONC. And this can happen from something as simple as a root tear of the meniscus, as you see here centrally, leading to marrow edema and setting off this progressive cascade of events. What we've looked at in our center is we've looked at the patients who have bone marrow edema with medial compartment pain. We've placed them in valgus unloader knee braces, and we've seen after 6 months, and these are volumetric MRIs where we've been able to calculate the amount of bone marrow edema, and we've seen an 82% decreased marrow edema over this period of time with unloader braces. So the osteoarthrosis cascade is initiated by joint injuries. It can also be by genetics or aging. The pathology continues with cytokine production and proteolytic enzyme production with matrix degradation. You then get inflammation and subchondral bone changes. In looking at this, you also have the inflammatory process of the synovium. You have breakdown of the articular cartilage. You have IL-1, TNF-alpha. You have really destruction of the articular cartilage, changing the loading of the bone, which then causes damage there with angiogenesis. And so we develop osteophyte formation and other changes in the subchondral bone that I'll talk about next. So in looking at the science behind joint pain, as we initially started, joint damage is not significantly correlated with severity of pain. And really the subchondral bone, periosteum, periarticular ligaments, synovium, and joint capsule are richly innervated and are the sources of nociception. And we find that bone marrow lesions, synovitis, and effusion have strong correlation for knee pain. If we just real quickly look at the normal process, on the left-hand side, we see the normal physiologic status. We have the calcified cartilage layer of a normal thickness. You have the normal articular cartilage with a normal appearing subchondral plate, the trabeculae, and the bone marrow cavity. In early stage of osteoarthrosis, we see some destruction of the trabeculae. We see bone marrow edema lesions. We see increased angiogenesis. The subchondral plate thins, and the porosity increases along with the cartilage degradation. If we then progress on the bottom here to late stage OA, we have further destruction of the cartilage. The calcified cartilage layer, you can see, becomes thicker, with subchondral plate being thickening and sclerotic with subchondral bone cysts. And this demonstrates the integrity of this whole unit, so that it's not just one articular cartilage layer or the subchondral bone, but an interaction. It's very similar, as you can see in this photograph. It is very hard to grow grass on concrete or blacktop. And so the subchondral bone health and the articular cartilage are intimately tied together. Thank you very much.
Thank you very much, John. It's been a great talk. And now it's our pleasure to invite Alberto Gobbi, as I said, past president of the International Cartilage Repair and Joint Preservation Society. He will move on to the treatment and he will present his osteocoroplasty. Please, Alberto.
Thank you to everybody. I'm really glad to see that there are people attending from all over the world. And this means that science has no borders, no ethnicity, no religion, and probably we are really global. So thanks to everybody for attending the meeting, and thanks to our chairs to have organized, Fabio and Dan. My topic is the treatment of osteochondral lesion with this technique that I called osteocoroplasty. Okay, so as Dr. Lane explained, the subchondral bone plays a major role in this kind of pathology, especially for the pain, because the pain does not come from the cartilage, but from the subchondral bone. And we consider now this an osteochondral unit rather than two separate structures. And when we consider the subchondral bone, we should consider the vessels, the nutrients, and as well as oxygen, glucose, biochemical signals, chondrocyte and mesenchymal stem cell that lie in the calcified layer. We have different kind of lesion, and we can consider that we can have a subchondral bone edema, but also osteonecrosis or avascular necrosis, as well as insufficiency fractures that are named SIFC, or spontaneous osteonecrosis of the knee, so-called SONC. So are different entities, and frequently they require different treatment. So there are several disease elements from an anatomic point of view, molecular point of view, and physiologic point of view to create the illness and the joint failure. And we should address all of this. The subchondral bone usually attempts to remodel himself, but if the pathology continue, we have the formation of bone cysts in a later stage, and we also have the formation of osteophytes, and the osteophytes form through the pathologic activation of the endochondral ossification that is mediated by the Indian hedgehog signaling molecules. And here is the picture. We can have several elements creating the pain because we have the bone marrow lesion, we have cartilage degradation, we can have associated frequently meniscal lesion, we have effusion, we have synovitis. So let's see what we can do when we must treat a organ injury that can affect the cartilage, can affect the meniscus, can affect the subchondral bone, and we should address all these different pathologies. It's important to consider that we cannot just treat the cartilage, because if you have cartilage degeneration, but you also have a subchondral micro damage, you have a diminution of the thickness of the subchondral plate, and this always happens in early stage. If you progress, okay, you're gonna have a large tear of the cartilage, but also you have the subchondral plate thickness that increase, you have the formation of subchondral bone cyst, you have a micro damage of the trabecular of the bone. We developed this technique that is osteochoroplastic, that is a minimally invasive approach for subchondral bone pathologies, that it's a technique that can be used to treat bone marrow lesion, insufficiency fractures, subchondral cysts, and also with some limit avascular necrosis. We published several articles regarding this technique, but basically I want to show you we have a bone marrow aspirate, and in order to have something that can help the healing of the bone, but also we harvest bone dowels autograft that we can implant into the lesion. In this study that we published on the Journal of Cartilage Joint Preservation, we follow up 24 patients treated with this technique, and we at 2 years of follow-up, we found a significant improvement compared to preoperative assessment. Basically, as I said, is a very minimally invasive approach and consists in 3 parts. The first part is a bone marrow decompression to decrease the intraosseous pressure and to remove the necrotic bone. Then we use the bone marrow aspirate, and we can use this in order to improve the healing potential into the lesion. But we also want to apply some bone autograft that are small dowels that we extract with this system. So basically we transplant some living, vital, intact bone core segment into the lesion. It's important to consider that the aspiration of the bone marrow it's particular. There are different techniques, and if we can force the aspiration with short blast of suction and we remove small amount of bone at the same time, we can really have a higher number of mononucleated cells into our BMA. This is the technique. I use this system in order to aspirate a small amount of bone marrow from different part of the idea crest. Usually you can see I aspirate very fast and a small amount in different position, and then I use a trocar to remove small bone dowels. This is the instrument. I pull the instrument all the way in, then I rotate 2 times, and I can extract in this way small dowels. I can take as many as I need according to the type of lesion and to the dimension of the cyst. Then I target the lesion with a fluoroscopy, and I can go directly into the lesion with the small dowels and through a small trocar. This is the bone dowel. I put into the trocar. I check that I'm in the right position, and I simply insert how many dowels I need. After this, I can treat cartilage, I can do arthroscopy, I can do cartilage transplantation, and I can check with arthroscopy the inner of the joint. Just briefly, I'll show you one example of a sport active 75 years of age male with a good range of motion, good muscles, but pain, important pain, crepitus in the external compartment of the right knee, impossible to run, impossible to walk long distance. And this is the MRI. As you can see, there is quite a big lesion. And this patient has been treated with this technique. And this is the preoperative, and this is the postoperative, because arthroscopy revealed that the cartilage was thin, but was still in good shape. And this is the patient, 75 years of age, very active guy. He is climbing most of the high mountain in Italy, and was treated with this technique with a fantastic results. If you want to know more about this technique and this treatment, I really suggest our books that we publish through ISAKOS, and I want to thank my co-authors, Bioorthopedics, a New Approach, or Joint Function Preservation, a focus on the osteochondral unit. Thank you very much for your attention, and I'm happy to answer to your question.
Okay, thank you, Alberto. And we'll wait for your questions at the end, if you don't mind. And I would now like to introduce Noga Shapson, who is in Israel right now, and she will talk about the radiologic assessment of subchondral bone. Her battery is low, so we'll have to cross our fingers.
Hello, everyone.
Hey.
Can you hear me?
Yes.
Okay, great. I could never imagine that I will give this talk from a parking lot near an army base in the south. I had the opportunity to go and visit my soldier son, which I haven't seen for a very long time, and hopefully I'll make it. My battery's low, but I'll do my best. Okay. In this talk, we will go over the imaging of the subchondral bone, and we'll talk about bone marrow edema syndromes and their classification and the prognostic factors that have to do with imaging. So let's look at this 68-year-old with chronic pain. On the radiographs, you can see a subchondral cyst. On the MRI, we can see that there is bone marrow edema there, but there is also another kissing lesion in the tibia. And on the radiographs, we can see that there is medial joint space narrowing. On the MRI, we can see why. And the reason is that this patient has a meniscus tear with extrusion, and the meniscus body is no longer functioning as a spacer. On the T1 weighted images, we can appreciate better the contour. You can see that the bone marrow edema is dark on T1. We can appreciate the contour of the articular surface and the osteophytes better. And what about CT? As you can see, CT shows focal osteopenia on the left. This is a patient with another bone marrow edema syndrome that is related to as complex regional pain syndrome. And what we cannot see on the CT is that bone marrow edema that we see on the MRI that is the source of pain in this patient. So what is bone marrow edema? Bone marrow edema on MRI actually describes, it's a term that describes high T2 signal. Is it sensitive? Yes, it's very sensitive. Sometimes it's even too sensitive because it's more sensitive than the symptoms. Is it specific? No, it's not specific at all. So this is why the correct term would be bone marrow edema-like signal, because it doesn't always reflect true edema. So how can we reach a more specific diagnosis? First of all, let's look at the T1. So look at the T1, you can see the image on the right. Look at the T1, find a close by muscle. If the bone marrow edema signal is higher than the muscle, it's not worrisome, and it's benign, and it's edema. It could be red marrow or contusions, fracture. But if on the T1, the signal is similar or less than muscle, then we're concerned. It is suspicious for infiltration or replacement of those fatty marrow cells by tumor or infection. So in this case, you can see a benign bone marrow edema, because on the T1, we can't even see it. And then we look also at the pattern, the location of the bone marrow edema, the distribution and extension, and combination with other soft tissue findings, but we're not going to discuss it in this talk. In this talk, we're going to discuss the non-traumatic bone marrow edema syndromes. Those syndromes are classified as reversible versus irreversible. There is an overlap because some reversible lesions complicate with osteonecrosis, and then they become irreversible. So osteonecrosis is irreversible. That's the classic irreversible lesion. And in this case, you can see an AVN on the left, in the left femoral head. It's chronic because there's no longer bone marrow edema. And also, you can see that there is fat inside that osteonecrosis, and it means it's chronic. And just remember, a person doesn't develop AVN just like that out of the blue. There has to be an underlying reason for that. The most common one is steroid treatment, also lymphoma treatment that contains usually steroids, and sickle cell disease and others. Reversible, let's look at the reversible bone marrow edema syndromes. And I think it's true also for all the bone marrow edema syndromes, that typically those syndromes happen to typical populations. And you can see middle-aged men and pregnant women, but when you look at it, then the more we know, they all affect the exact same populations, which means they're probably this MRI for this patient. We will see that it's actually an insufficiency fracture. So how can we tell if there's how can we tell if this is a edema is reversible or irreversible? Well, if it's only the bone marrow edema and that's all, it's reversible. But if there's also a band of low signal, or if there's a change in contour, it's already irreversible. So this is an example of a reversible lesion, because you can see that there's only edema here, but the contour is normal and we don't see a band of low signal. This is a 42-year-old, and you can see that the patient presented with bilateral edema in the femoral heads. This is a T2 sequence without fat suppression. You can see that the bladder contains bright urine, and that's why it's a T2. But still, because there's no fat suppression, we can see the contour and it's maintained. And after 2 months, the edema is almost completely resolved, but there is still residual edema, and we can see that there is already significant cartilage loss here, which is diffuse and bilateral. So one would call it transient osteoporosis, and another one would call it regional migrating osteoporosis, and therefore you can really see that they're all the same. And this is an example of an irreversible lesion. You can see this bone marrow edema in the medial femoral condyle, and there's a band of low signal. which is an indication that it's irreversible. And after 10 months, you can see that the edema near completely resolved, but there's already flattening of the articular surface. You can see the same after 24 months. Recently, a new MR classification has been suggested, which correlates with the prognosis. So basically, if there's just bone marrow edema, even if there's a fracture line, it's considered as a low-grade lesion, and the improvement rates are good. They're more than 50%. However, if there's a secondary osteonecrosis of the subchondral fragment, if there's an osteochondral defect, subchondral cystic changes, or associated findings, posterior meniscal root tears and extrusion and severe chondrosis, then the prognosis, it's a high-grade lesion with a low or a poor prognosis. Remember that about 3% of patients with these syndromes are being missed clinically because clinical symptoms can be misleading. And then they end up getting the opposite treatment. They get weight-bearing exercise instead of the opposite. That's why MRI is important. What about the epidemiology of these bone marrow edema syndromes? And now I'm talking about SIFC, spontaneous insufficiency fracture of the knee, but it applies for all. So first of all, what is an insufficiency fracture? It means normal stress on an abnormal bone. It used to be thought that it's more common in females, and then there was equal distribution, but now we know it's even more common in males, 5th and 6th decade of life, and it affects mostly the MFC, although it can be anywhere in the knee. Patients present with sudden onset of pain, rest pain, night pain, or worsening of their usual pain. There's a strong association with medial meniscal posterior root tears and extrusion, meniscus extrusion. And the association with diffuse osteoporosis, general osteoporosis is actually in debate. And you can see here an example of an extruded medial meniscus along with an irreversible insufficiency fracture. What is known is that there is an increased bone turnover in these patients. This is an example of a 52-year-old. He has bone marrow edema and evidence of an irreversible lesion, the band of low stigma. But when you look carefully, you can see that there's also edema in the lateral femoral condyle and another irreversible lesion. Although there's cartilage, the subchondral bone is already damaged, and cartilage defect will come in the future. This is an example of a patient that has an insufficiency fracture. You can even see the fracture line. It's still reversible because there is no osteonecrosis of that fragment. But here there's no meniscus extrusion. It means it's not written in stone that there will be meniscus extrusion. This is an example of the same patient that over a short period of time had transient osteoporosis in the medial femoral condyle, and then it improved. And then he had an insufficiency fracture with a fracture line in the lateral femoral condyle that improved. And then he developed one in the lateral tibial plateau. And lastly, in the left femoral head. So as you can see, it's really hard to decide what to call it. They're all insufficiency fractures at different stages. What are the outcomes of SIFC and what can help? First of all, it was shown that even one session of physical therapy and shockwave therapy actually helped. But this is not related to imaging. When we talk about imaging, there are poor prognostic factors. There's a long list, but I would like you to focus on the size of the lesion because that's something we can measure on an imaging, meniscus extrusion, and also lateral meniscus root tears and extrusion. This is an extreme outcome, an 84-year-old patient that had a meniscus tear and an insufficiency fracture. And look what happened 10 months later. There's a complete destruction of the joint. This is a patient that participated in a clinical trial. And you can see that his first study was done as a clinical study because of his pain, and there is extrusion of the medial meniscus and some edema around the MCL. 2 months after he came, just because of the research, that was the timeline of the follow-up MR study, and now there's already complete destruction of the joint, complete cartilage loss and bone marrow edema, and as you can see, he developed osteoarthritis. That shows you that sometimes these patients can be imaged too early. And therefore, if you don't see a bone marrow edema syndrome, but symptoms persist, then follow up with an MRI. And this is the other spectrum. This is a 63-year-old male, and you can see that he has an insufficiency fracture in the medial tibial plateau. There is a fracture line, but that's all. And this is a low-grade lesion, and you can see that it completely resolved. This is the only slide I'll show you about treatment, just to show you that small lesions and low-grade lesions are something you can see on imaging, and these will be treated conservatively. The others will be treated surgically, and that's for another lecture. What about prevention? As of now, the only way to prevent it is that we know of is if there's an acute posterior root tear, then it's better to repair it, to do a pull-out repair as soon as possible. So how do we know that if we see a tear, a root tear, how do we know that it's acute or it's just about to happen? If we see this bone marrow edema adjacent to the posterior root in the tibia, then it's better not to wait. If I see this, I actually call the orthopedic surgeon and I report it over a phone call, so they know to call this patient back and treat them fast. So in summary, we went over bone marrow edema syndromes and the classifications and what we can see on imaging and the population. We spoke about the early root repair, and it's important to know to image those patients fast, and if you still suspect it and wasn't seen on imaging, then it's sometimes good to do a follow-up study. And lastly, I would like to ask for all your help to bring those people, kids, elderly, children that were split from their parents, please bring them home. Thank you.
Thank you, Noga. And thank you for delivering this under these conditions. So
Yes, in the meanwhile, just before we upload the case presentation, since we have Noga still there, I would please ask you, since it has to be a very teaching webinar, from the radiological point of view, what's the timing of the follow-up MRI follow-ups you would suggest as a radiologist, just to squeeze them and see as our clinicians would answer there?
Actually, if the patient, we know that the patient has an insufficiency fracture, then I'm not even sure that there is a need for follow-up unless the patient has symptoms, because you know what happened, you know, the rest is depends on the patient's symptoms. If you suspect that there's an insufficiency fracture and you didn't see one, I don't think there's no risk about it, and I would say, you know, do it within 1 month, because after 2 months the bone marrow edema will start resolving. So I would do after about 1 month or 2 months or whenever. There's not a true answer for that.
Yeah, absolutely. Yes, I think that's also as a clinicians, that's normally what we ask the patients to do. So we are ready, I think, to start presenting the 3 clinical cases we have organized for the discussion. And I please invite Alberto Gobbi to be presenting them because he is attaching these cases. Please, Alberto.
Thanks, Fabio. I'm ready. Can Laura put the cases, because I sent her. If you can put the cases on the screen. And I want to tell Noga that we are really with Israeli people, and we understand, we suffer, we share the sufferings, and I hope that our government will do the best in order to have the hostages released. Okay, this is a case of a 71 years male with a history of chronic left knee pain. He had no trauma, and the pain was basically on the medial joint line, no malalignment, no instability, no history of pharmacologic treatment, cortisone or diabetes. Next, please. Okay, here probably Noga can comment on this much better than me. I can see that this hyper-intense signal in T2 weighted MRI. There is a bone marrow lesion, quite extensive, and there are no meniscal lesion. There is no extrusion of the medial meniscus. I'm happy to have any comments from Noga if she wants to intervene. I'm really happy.
Yeah, sure. What I would like to comment on this is that probably there is no osteonecrosis here, so there is a chance. There is a chance that this is reversible. Another interesting thing is I want to show you that edema along the MCL, and you see that it extends beyond the proximal attachment of the MCL along the metaphysis of the femur, and also on the muscle, a very typical sign for an insufficiency fracture. And therefore, although there can be other lesions for subchondral pulmonary edema, in this case, it helps us to diagnose that this is truly an insufficiency fracture. This is a low-grade lesion.
Thanks, Noga. Yes, I agree. Can we have the next? So basically, in our opinion, the possible diagnosis was a reversible lesion, as Noga confirmed, and the lack of additional subchondral changes other than the BME suggested us to treat this lesion. The possible treatments were non-surgical treatment like physiotherapy or pharmacologic therapy, decompression alone, or the osteochondroplastic, that means decompression of the lesion, infiltration with bone marrow aspirate, and implantation of bone autograft to provide a mechanical support. I will be happy to have any comments from all the team.
Yes, Alberto, before you move on what you did, I would please ask John and Nori, would they go for firstly for a non-surgical treatment? And in that case, what would you think about unloading braces or unloading the patients or some specific drug? Or would you move directly to the surgical possible treatments? Please, John.
Yes, thank you, Fabio. In a case like this, I would probably initially try an unloader knee brace.
I would.
Yes, go on, John.
I find that quite often that the people can get resolution, especially when it seems very reversible. It's hard to know exactly how much the brace adds, but it's similar to restricting them with crutches. And so I found that that can be very effective as a first step instead of necessarily going ahead with surgery, although I'm sure Alberto has already exhausted some of those conservative treatments at that point in time.
Would you go for some drugs, diphosphonates or other possible available pharma drugs?
I think that's an option, yes.
And let's see what Nori from the other side of the Pacific would suggest. Would you go for a non-surgical treatment or surgical treatment, Nori?
Okay, can you hear me?
Yes, perfect.
Yes.
Okay, Sorry, there is a trouble in the video image, but I do like to treat this patient conservatively. And I even don't use any, brace for changing loading condition. I believe without any additional pathology, this is a kind of transient osteoporosis-like lesion, and I'd like to wait. According to the literature and through my experiences, the patient's symptoms should disappear in several weeks.
So you would agree with us and with Noga before, you should, let's say, tell the patient just to unload a little bit, do the treatment, do the pharmaceutical treatment you will suggest, and come back to you in 1 month and repeat an MRI? Please, Nori.
Oh, okay. Actually, I rarely take additional MRI. In case patients still have persistent some symptom, I will take MRI once again. But I used to did a core biopsy of such bone marrow lesion without any concomitant, pathology like a menisci or cartilage. I did find any pathology from the bone marrow. So I just decided to wait and see what's happening.
Nori, would you ever go just for a MSCs or bone marrow concentrate injection treatment as a treatment?
I believe this is a kind of the last option. So if any, conservative treatment doesn't work, I will do such, manipulation of the bone marrow conditions.
Noga, any suggestion from you? You would keep it as a checkup in 1 month? You would go for other type of radiological evaluations?
Were you asking me? Sorry.
Yes. Did you catch my question?
No, I didn't.
I was just asking if you would suggest other possible imagings or follow-ups in a case like this.
Well, I actually think it may be an irreversible lesion because after you moved on to the next slide, it was also the sagittal, and I was wondering if there was a band of low signal on the sagittal. So if I think that it may be a treatable lesion, then yes, you can do either a follow-up study, but not way too much because you still want to try and save the bone. The subchondral bone unit, the cartilage, the underlying cartilage. But if I'm sure that it's reversible, then no, because if the patient has symptoms and maybe the patient has irreversible damage, there's nothing we can do.
Okay, thank you. So, Alberto, please, I would go back to you and show us what has been your choice of treatment.
Okay, so I think that I could not hear very, very well the comment that Noga said, but I think that one very important issue is how long should we continue with the conservative treatment? Because I think that here everybody agrees that we should at least start with the conservative treatment, and this is what we did. So we started with the conservative treatment. We suggested the patient to have a partial weight bearing. At the beginning, we tried with the brace, but he did not tolerate the brace. Now, together with John Lane, we are working on new unloader braces that could be maybe better, but the braces that at that time, this case is a few years old, they didn't work. So the patient did not tolerate it. So we asked him to use crutches and partial weight bearing and to do magnetic field therapy. And this lasted for three months, more or less. But then the patient was absolutely annoyed and he wanted to have something different because he said, I cannot continue walking with crutches. So we also don't know exactly how long we should continue with a non-surgical treatment. So we decided to move to surgical treatment, and we wanted to do arthroscopy to check the joint from inside, and then to do the osteochondroplasty technique. Can I have the next slide?
So, the poker.
Okay, so basically, we went in the OR. Arthroscopy revealed a joint with, of course, some degenerative changes, but we just cleaned, and there were no major lesions. So we target the lesion with with the fluoroscopy, and we use the osteochondroplasty. Next, please. Exactly as I showed before. So again, here we have the preoperative images. After osteochondroplastic, the patient should continue with partial weight bearing. Of course, we do not allow full weight bearing. And this is the image at 2 months. And 2 months, the patient was doing much better. So we allowed him to restart walking without crutches and going back to normal activities, no sport activities. But slowly, he resumed every activity at 6 months. And this is a follow-up check at 12 months. Next. And this is the patient. He's not an athlete, but he healed very well, and he was able to go back to every activity.
So that's a great result, Alberto. About your osteochondroplasty from the audience, we have also another question where they ask if you need to localize the lesion on a 2D C-arm, or it has to be located three-dimensionally to have the accurate location and have a better possibility to have the correct treatment.
Well, of course, if we could do it with 3D, it would be more precise, but we don't have the facility to do it in the operating room. We have just fluoroscopy, but we always have in front of us the MRI, so we know where the lesion is. And then we use fluoroscopy and in AP and lateral view, and we think that we can be quite precise, especially because these are quite big lesions. So I think the target can be reached.
Very good. I think if we haven't any further comment, I would go on the case 2 osteochondral lesion presentation, please, Alberto.
I'm happy to do it. I saw some question that probably Noga should answer, because one question was, how can we differentiate bone marrow edema from an early infection? From my point of view, I do it from the clinical point of view, no fever, no sign of infection, but honestly, I don't know how to do it with MRI, but I'm not a radiologist. Maybe Noga wants to answer to this part.
Yes, so first of all, I don't remember, not even sure I remember even one case that I had a dilemma when I looked at the MRI. When you look at the radiographs, both of them will have joint effusion, both infection, but also if I see joint effusion in a patient that is in the right age and doesn't have clinical history of trauma, I already suspect that that patient may have an insufficiency fracture, because why would a patient have joint effusion without trauma? Unless there was a small piece of acute cartilage defect or acute meniscal tear, or a bucket handle tear. Otherwise, OA, just like simple OA, not during the therapy, won't even explain joint effusion. However, remember to look at the T1. If you see T1, then infection is an infiltrative process that extends gradually, and it doesn't have sharp margins. If there is a low band of low signal, and it has those sharp margins that has the appearance of a lens or of the band, then that may be necrosis of the insufficiency fracture. But otherwise, if there will be a low T1 signal lower than the muscle with indistinct margins, and you suspect that there is an infection, then tap the joint.
Thank you very much, Noga. Now we know that the technical issues have been solved. Please. So we are very happy to know something about the possible regenerative treatments of this bone marrow lesion with mesenchymal stem cells. Please, Nori.
Okay, thank you very much. And so I'd like to have you the topic of the potential future treatment using stem cells for the osteochondral lesion. Next slide, please. Okay, in osteoarthritic knee, especially at the advanced stage, there is a prominent, disorders at joint surface, including cartilage and subchondral bone. And at that case, we do need to replace such a, deteriorated lesion to the new osteochondral unit. Next slide, please. So, but to attain the very good osteochondral repair, we do need a biphasic zonal repair is required. So cartilage part and subchondral bone part. Next slide, please. Yes, and for the chondral part, we succeeded in treat such lesions using stem cells without the use of any biomaterials. We let the cells produce the matrix to create a three-dimensional body, and we implanted such cell matrix complex to the chondral damage lesion. And we attained a pretty good chondral repair in clinical cases with very good tissue integrations. Next slide, please. But this construct fails to repair osteochondral lesions. As you see these slides, even though we implant this construct to the osteochondral lesions, we could see no repair of the subchondral bone. Just a lesion is, depressed as it was. Next slide, please. So at the first stage, we decided to use some, ceramics, artificial bone, and by making the complex of that tissue engineered construct and artificial bone, we implanted this complex. And next slide, please. And as you see, we can see the very good, repair of cartilage with a good tissue integration to the adjacent, cartilage, lesion. So this was a kind of the second step. Next slide, please. But if we can restore such osteochondral complex unit by only the cells, that should be the major breakthrough as a future treatment. Next slide, please. How can we do that? For that, we actually needed the presence of the this iPS cells derived cartilaginous particles. iPS cells can differentiate into any lineage tissue with abundant proliferative potentials. And Dr. Tsumaki in Osaka succeeded in creating the cartilaginous particle, pure particles from the iPS cells. And next slide, please. And we found that the solution for the scaffold-free osteochondral repair. How can we do that? Next slide, please. Next, please. Okay, next, please. Yes. We wrapped such iPS-derived chondral particle by the tissue engineered construct and implanted this complex to the osteochondral defect. Next, please. Yes, and you can see the rightest column shows a very beautiful osteochondral repair when we implant the complex of the IPS particles, wrapped by the tissue engineered construct. And very interestingly, if we once freeze the tissue engineered construct and kills all the MSC within the construct, there is no such, subchondral repair detected. Next slide, please. So, with the current stem cell technologies, osteochondral repair is available without the use of any biomaterials. So, with a complex of the iPS cell-derived cartridge particle with tissue engineered construct, we can very beautifully restore the osteochondral complex. Of course, the safety issues with the use of the iPS cell-derived materials, we should take very carefully the several issues. But in near future, we can treat such osteoarthritic condition with cells without any biomaterials. Next slide, please. Thank you very much.
Fabio, thank you, Nori. Wonderful talk. Really enjoyed it. Fabio, do you want to make any comments or answer any questions at this time?
Well, I'm very happy to have, as you know, I love the MSC, so I'm very happy to have the regenerative stem cells coming in the discussion. But before going to Nori, I would like to, there's a question about the fact that if steroids can be one of the causes of osteonecrosis. Obviously, I certainly say yes. We all know perfectly that there's an important induced osteonecrosis by steroids. Maybe John Lane, that took the conservative options, could add some words about it before we move to the second case discussion with Alberto.
Thank you, Fabio. I mean, it's quite clear that steroids are a major issue, and especially in patients that you've seen that have some type of cancer and have some regimen that includes steroids or other rheumatologic disease. I think you develop severe problems with osteonecrosis. So I'm very cautious about using much steroids, a lot of Nedrol dose packs, things like that, because I think there is a predilection to this whole problem. One other topic that I see as one of the questions that I think we should address is the use of subchondroplasty as that has been characterized, and I think we should discuss that topic.
Yes, absolutely.
And Fabio,
Yes,
can I have one comment?
Yes, certainly.
Nowadays, I believe the use of the PRP can replace the use of steroid. Steroid, it has a drastic effect to suppress inflammation, so should be good for the pain relief, but PRP can substitute the steroids, and PRP can be available for the repetitive use without any induction of the cell death, tissue necrosis.
Absolutely. The anti-inflammatory power is quite well described in the literature, both for PRP and also if we want to go back to MSCs also. Yes, Alberto.
Well, I want to connect to what Norris just said. It is now a couple of years that we started also using in the office the use of PRP into the bone. Ramon Cugat showed me how to do it. It's very easy because with a simple needle, sometimes you use a little bit of local anesthesia, but it's not very painful. You can penetrate the bone. It's very easy, especially in the elderly patient, because you go easily inside. And can be a good idea to inject in the office before doing a minimal invasive surgery, but is still surgery. I agree with Nori. Sorry about that.
Can I ask a question of Nori also? Wonderful talk, Nori. I just have a question. how would you, how would you translate this to the clinic for a lot of patients? And would the MSCs be autologous or allogenic? And what about the possibility of using EVs or exosomes instead of the MSCs with your bone materials?
Okay, let me have the comment. Actually, we used tissue engineered construct that is from the synovial MSCs, okay? And we wrap the IPS derived cartridge. And there's likely some communication occurs between the MSC and cartridge, like differentiated cells. And very interestingly, when we freeze the tissue engineered construct to kill the cells, there is no, osteochondral repair, detected. So that means the presence of the living cells within the tissue engineered construct is very important. And I'd like to say, in the matrix, with freeze frozen cell death, there are many abundant exosomes left. But nonetheless, exosome did nothing. So I still believe the presence of the living cells is important for doing something. The mechanisms still remain unclear, but I just found a very interesting phenomenon.
Yeah.
Thank you.
I think we will have an additional 10 minutes, and I will use them to have the second case from Alberto and then the final future ideas from Nori. So Alberto, please go ahead.
Okay, ready to move to the next. This is a lady, 81 years of age, very difficult patient for me because she's the mother-in-law of my sister. And she wants to play golf, and she wants to, she's not 81 years. In her brain, she's still 40 years of age. And she had this osteochondral lesion in her left knee with a minimal joint fusion, minimal fluid distension of the Baker bursa, good mobility, but severe pain, especially she could not walk longer, she could not play golf, and she did not want to undergo a total knee replacement. This is first things to consider. So she was asking me a sort of miracle as a biosurgeon. So she said, you should find something, do what you want. And can I have the next slide? Okay, this just to clarify that she did not want to have a uni or a total knee replacement, even if she was more than 80 years of age. So this is the first things to explain, because maybe somebody can say, well, do a uni. No, she said, no, absolutely. So we had to understand if this was reversible or irreversible based on the subchondral band and the side. So I was quite skeptic about this. I thought that was a microtraumatic bone lesion because she was charging the knee, what we call, weekend warrior. She was going to golf 3 times per week. And but the dilemma was also if this was an osteonecrosis and if we could treat with a simple treatment. Again, we started by giving some medicine like alendronate and magnetic fields and rest. I put the brace, but the pain was so. At rest, it was okay, but as soon as she wanted to walk or to even to do more, was really, really painful. So it was difficult for me to decide, and I would be happy to have your comments on this.
Did you try an intraarticular or intraosseous PRP as Nori was suggesting before? Do you
I
think?
tried intra-articular, but not intraosseous at that time, because as I told you, we started in the last 2 years, and you can see from the date, this was 3 years ago, and so I didn't do intraosseous, only intra-articular, but didn't work.
All of you would agree on the fact that it's an overloading medial edema due also to a virus that we can see, and obviously also to an overloading of function.
I'm not sure, just because at the beginning, assuming that that's how all the images look like, and there's no additional information on the consecutive images. But first of all, she has this extruded torn meniscus. She has narrow joints, but she already has advanced osteoarthritis in this case. And she has edema along the medial tibial plateau and soft tissues. That means probably it's an insufficiency fracture. But in this case, she already has extensive cartilage loss and squaring, flattening of the articular surface of the medial femoral condyle. So she anyhow has advanced osteoarthritis. I don't know if that helps you to make treatment decisions. But,
Agree. I agree with Noga. I agree with Fabio. So there is an overload of the medial compartment. It is a varus knee, not very important. We had a long leg standing. It was 7-8 degrees, no more, but there is a varus knee. At the same time, I was not sure it could be a good idea in an 81 years of age person to do an opening wedge osteotomy. So I was thinking something easy, and my idea was a sort of unloader brace that at that time we did not have. Can I have the next? So in my mind, I said, okay, what is the target? The target is to decrease the pressure on the medial compartment to fix the intra-articular lesion, maybe just with a simple shaving, and to put some healthy bone into the medial part of the tibia. Next. So basically what I did is a proximal fibular osteotomy, arthroscopy, shaving, and osteocoroplasty. This is a procedure that is not widely used. I learned this in India because patients with a fracture of the fibula, that is quite common because police used to beat motorcyclists with a long stick, and they found that people with a fracture of the fibula, they had less pain in the medial compartment. So I did this. Next. And this is the follow-up. So we can see that from the pre-op to the post-op at 1 year, absolutely a change of the situation. Next. This is the 2 arthroscopic portals, so very minimal invasive surgery, and the small incision for the proximal fibular osteotomy. She started walking 2 days after the procedure. Next. She went back to golf and to all activities. So I think it's a particular treatment for a particular patient. I would be happy to have your comments and your criticism as well.
Alberto, congratulations on your very unique, treatment. This is very unique and reasonable, I believe. And if anything, I'd like to suggest to focus on the osteophyte at the medial side, plus meniscal extrusion. And I believe when I see the ultrasound guide to see the movement of the motion of the meniscus, in such case with prominent osteophyte formation, menisci actually moves when extension it's extruded, but with flexion, it's coming at inside, lateral side. And I believe such a motion can stimulate the formation of the osteophyte. And if the lady's symptom is specifically at the medial side of the joint, I believe the manipulation of such structure, for example, arthroscopic shading of the osteophyte plus meniscectomy could control her activity. Yeah, this is my personal idea, but your strategy is very, very unique, and I'm impressed. Thank you, Alberto.
Thank you, Nori. I also agree. Best congrats, Alberto, for presenting an interesting case. I would just like to ask John, as a US surgeon, what would have been your first idea, a medial partial knee replacement? John, are you there?
Yes, thank you. As things have evolved, I think what I'm doing right now is there's a new, basically a shock absorber medial implant. And I think that's what I would do. It's very similar to what you would get with an osteotomy. It unloads the knee. And as you go into extension into your weight-bearing area, the piston is pushed apart, so it unloads that medial compartment. So I found that that's the treatment that I would do. It's very minimal. Patients are back walking within a week or two. And it really is sort of a minimal kind of similar to a joint replacement. And that's where I would go with, especially with someone like this.
I also, John, had great results with the Atlas medial absorber. It's a good option. Obviously, Alberto maybe did something even better, proposing this easy osteotomy and injection and occurplasty treatment. We are 10 minutes over our time, so I think we should leave the last 2 or 3 minutes to Nori to his future considerations. Please, Nori.
Thank you. So you must have enjoyed today's program, and as you see, to discuss the joint surface and subcontrol restoration, we do need the multidisciplinary approach. So we do need surgical intervention. We do the VEST high resolution imaging, and we do the we must know that we must understand the biomechanics and biology. And so I think these topics can be a very good example to discuss the future of the medical science. So hopefully we can organize this ISACOS ICRS combined program to focus on the bio-orthopedics. Bio means not only biology, but also biomechanics. So we looking forward to the another future opportunities to share the experience with you. Thank you very much.
Thank you, Nori. Absolutely agree with you. I want to thank all the speakers, and I want to thank all the audience from all over the world. It's been a great experience, and I would leave the last words to our ICRS actual president. Dan, please.
Sure. So once again, I think I'm very, very excited about the breadth of our international attendees for this conference, and I look forward to working with all of you in the near future. Thank you.
Thank you.
Thank you for inviting me.
And thank you to ISACOS for and the program committee here helping us behind the scenes. It's really quite amazing. So thank you for that as well.
Thanks, Noga. Thanks, Noga, for coming, and I wish you the best luck for your son that is such a difficult situation. Thank you.
Thank you
Yeah,
so
thank you, Noga, for joining us under such a difficult time. I really appreciate your contribution. And talk to you
Thank you
soon.
so much.
Best wishes, Noga and everyone, and thank you.
So all
Bye-bye.
of you,
Thank you.
Great.
thank you, everybody. All of you from the audience continue to follow ISACOS and ICRS events and enjoy joint preservation. Thank you all. Bye-bye.
right.
Thank you.
All right.
Bye-bye.
Bye-bye.
Take care.
Thank you.
Bye.
Bye-bye.
Bye-bye.